Good morning, everyone. Thank you for joining us for Access to Mental Health Care 2.0. Rebecca first did the Access to Mental Health Care last July, so this is an updated one to give home visitors a good idea of how to refer their clients to mental health care services. So many thanks to Rebecca Hurtado from DMH for agreeing to present. And without further ado, I'm going to hand it over to Rebecca.
Thank you. So for today, what we're trying to, the objectives for today's training is really to increase the home visitors' awareness of Department of Mental Health in general, build knowledge base on how to access these services, and identify when and how to refer your clients to DMH services. But first, we'll start a little bit about the department in general. The Department of Mental Health is the nation's largest county-based public mental health service. We serve over 250,000 clients annually. We run more than 85 directly operated, in other words, DMH actual clinic sites, and provide services through many contract providers in approximately 300 additional sites. We're also co-located with other county departments, schools, and courts, and various organizations. Each year also we have more partnerships. Starting last year, we've been building a lot of partnerships with the Department of Public Health. We definitely have partnerships with DCFS and other departments as well. Our main focus really as a department, this is our director and the mission, but really is that our services can really provide dignity for our clients, increase their hope. Obviously, we want clients to be well, to recover. But we also want to instill a feeling of resiliency. We want to help them, and we will ultimately would like to make them feel that they can be part and reintegrated part of the community. Oftentimes, our clients feel secluded and segregated, but that's something that we really work at through our services to be able to increase all these things. This is basically a copy of, for most of you might be aware of the county and how we're divided. We follow the way the county department, the county divides the county, which is into 8 service planning areas or service areas. So you will see in this map, like service area 1 is more like Lancaster and Palmdale area. Service area 2 would be like your San Bernardino area, and so on. And we have directly operated clinics and contracted providers all throughout the county. So the populations that we serve, basically 0 to whenever. Oftentimes we divided a lot of our programs between child 0 to 15, transitional age youth 16 to 25, adult 26 to 59, older adults over 60. We're not using so many age groups in our programs, but one of the things about this is the importance some of our programs really specify on the special needs that a child has at 0 to 15 years or their families, which is going to be very different sometimes than an adult or an older adult. And the funding types that we take is mostly clients have Medi-Cal, indigent funds as well, and sliding scale. So this picture or this slide really is just to give you a little bit of overview of how our services are kind of created. Oftentimes we're asked, what services this, what can we do with this client? A lot of times we think of mental health as a continuum. There are clients that we meet at a stage in their lives in which they really are just developing something, or they just went through grief and maybe nothing is really happening at that moment. And a lot of times, unfortunately, oftentimes we meet a lot of clients when they are inpatient, and this is the first time they start getting mental health services. So they've been hospitalized because they had a psychotic breakdown or they attempted suicide, etc. So this is an overview of our services. We have prevention services, and the way we change that up or divide it is universal prevention targets general public as a whole, and it's the idea of really reducing stigma of mental health, that providing the understanding that taking care of your mental health is just part of being human. Just like taking care of your physical health, it's important. Eating vegetables, exercising the same way as it is to talk to people, to try to find activities that find enjoyment, to try to find activities in which you can connect with others, and so on. Then you have selective prevention, which we target individuals at risk of developing mental illness. And this at-risk category really a lot of times has to do with, for example, as we partner with DPH and home visiting, a lot of times some of the programs are targeting a group of moms that are more at risk for different things. Either they have lower income or they have high risk of pregnancies. So you can say that by us doing certain trainings for this group of people, for you, it's like targeting, because we know you're going to be working with those individuals. But another example of targeting or selective prevention targets using trainings is, for example, sometimes us doing trainings in the community with family members of parents or relatives of children that are in the Department of Children and Family Services, or that they're already receiving our mental health services, for example. But the idea is that we're educating them in understanding that, hey, there are things that you can take or do to take care of yourself or to prevent this. Then early intervention really is, you have a child or you have anyone who is really, this is the first time they're experiencing something going on in their life. It can be grief, or they're starting to feel depression. A lot of times we focus on youth when it comes to early intervention, but it could be at any age. And some examples of that really are evidence-based practices that we have, which is usually short-term therapies. Then we have our outpatient, and I put this not so much of a continuum, but in understanding that we have all these locations that we talked about. Many of our clients, and most of our clients, do go to a clinic and are seen for either therapy or psychotropic medication. Sometimes it's partially field-based, but most clients that are seen in the outpatient world are really clients that can, take care of their day-to-day and just need additional support. They either need to talk to somebody or they need some case management services and some psychotropic medication. A lot of times, the services that we provide in outpatient is for individuals that need ongoing psychotropic medication, meaning they see our psychiatrist. Some examples of that are recovery, resilience, and reintegration programs, our intervention programs. Then we have the more intensive programs. Intensive services are mostly field-based. 24/7, they have a 24/7 crisis response component, which means that, for example, the client or the mom calls this team and say, my child's not doing well, or I'm not doing well, I'm having these symptoms, I'm having these suicidal thoughts. And the idea is that they will go to the home physically and try to see how they can assist in order to prevent that person from actually being hospitalized. So these services are provided only for those that already enroll in these programs. They have a multidisciplinary team, and an example will be full service partnerships. We have other programs, but some of them are really it's specific to either jail or DCFS. Then we have the residential, which is a little different, but like, for example, they're either at a hospital or they're in a locked placement. And the last one's really just, I wanted to emphasize the partnerships that we have, and some of the programs that we created with these different partners are a little different. Like we have, for example, for DCFS, we created things such as specialized foster care. We have other things with DPSS. We're also at the courts, and we have court mental health. So we have these different programs that we also provide actual mental health services for their clients. So this is really just the prevention mission, because this partnership with DPH and the home visiting has began from the prevention services, is to engage, outreach, and develop partnerships in order to create trauma-informed organizations and communities to mitigate the impact of trauma and aid the prevention of mental illness. So really the focus of today's training is for you as a home visitor to be aware about the mental health and about mental health services, and that you can link your clients to mental health, that mental illness exists, but also that recovery exists, in order for you to be able to, when you're engaging with your clients, maybe be able to engage them into mental health if you think that's something needed. Oftentimes, there's a lot of stigma about mental health, and given the fact that you're already working with the families, you might be that one person that is able to let them know, hey, there are services out there. Oftentimes they're either low pay or they're free in order for you to be able to access them. So what do our preventions look like? And again, I think we've kind of talked a little bit about this already. So defining mental health. Now, this section is really going to be talking briefly about some symptoms before individuals ask us about a little bit of symptomology. So I'm going to be providing that in this brief section before we go into actual mental health services. So mental health really is emotional and psychological and social well-being. Again, it's something part of everybody. It's just our psyche. It affects how we think. But when you have a mental illness, it affects how we think, how we feel, and act. But even if you don't, right? If you're not well in this area, or you are, this is going to affect how you think, how you feel, how you interact with others, your decision making, your desire to do different things. And it determines basically how we handle stress, relate to others, and make choices. So it's obviously taking care of our mental health is extremely important. So common symptoms in children, for those home visitors who work with families who have multiple children or children a little older, changes or irregularities in sleep habits and eating habits. This is something, oftentimes there are some changes that happen right away in children, that this is the first thing you see, not necessarily the child showing any emotions, but you start seeing some of these symptoms. Or they start having actual emotional dysregulation. A child who usually was able to play with others is no longer able to play with others, or somebody takes a toy away from them or gives them time out. It's extremely dysregulating. And as the person that you're either working, or the mom or the parent, somebody who's taking care of this child, just feels like it's so odd. He wouldn't or she wouldn't act like this before, or it doesn't make sense to what's happening. It's a little bit too much for what's happened. Also, then we have development and milestones. Sometimes children who, especially 0 to 5 children who are not emotionally well, either they have many things going on. There's domestic violence, there's maybe substance abuse or other things going on in the house. They might not be getting the attention that they need. So you might start seeing some miss some developmental milestones. This doesn't necessarily mean that the child's not going to reach those milestones, but you might see this more delayed, or just a loss of some of them during this time. Response to So obviously, response to environments refers to how are they reacting to what's going on outside. Doesn't make sense. If you would think about a child that age, would they react this way? For older kids, poor school performance, and it's very telling. A child who's been doing pretty well or okay, you start seeing a decline. But sometimes you find children that continue to doing well, and so So my caution with this is, don't just focus on school performance as an actual tell-all of how the child is doing. You really want to look at the other issues, and also what the family is probably telling you, or he or she is expressing. And then some psychosomatic complaints, which is not feeling a lot of stomach aches, feeling a lot of headaches. A lot of times children who are getting bullied, when it's time to go to school, or Sunday at the end of the day, you start getting a stomach ache or a headache, or something's going on because of the fear of going back to school. So common symptoms in adults, and the reason why I'm giving adults is because most of your moms are the ones that your programs oftentimes are doing some screenings on, they're doing interventions on. Obviously the children's important, but the adults is extremely important. As we work with families, and any family, even mental health programs, we got to work with the parents or the caregivers, and their well-being impacts the well-being of the child, even if the child is the client in the mental health program. So for example, we have prolonged changes in mood. Somebody who had a positive mood no longer is able to express that. Changes in sleeping and appetite is extremely important. I think sleeping is extremely important. Sometimes when you engage people, they're more likely to tell you if they're sleeping or not sleeping, rather than I'm feeling depressed or things I have in my head. Granted, with pregnant moms or postpartum moms, that's also important. for you to consider as well, because that could be that they're not sleeping because they're feeding a child. But what is their level of the when they're expressing? What is their what they're telling you besides not sleeping? So listen to that. Unexplained physical complaints, changes in mental state or thought. For example, not feeling just feeling not so much overwhelmed, but more so feeling that they cannot do something, or they're just not good at this anymore. They're not good at being a mom, or they can't handle certain things, or the constant thoughts in their head. What is going on through their head? Seeing or hearing things, or talking to self, obviously with some psychosis. Growing inability to cope with day to day. In order, a mom, for example, maybe was doing okay, and all of a sudden you come to the house, it's no longer clean, it's unkept, and the longer you pass, more you're noticing more of this thing. So something's going on with this mom. Obviously, suicidal, homicidal thoughts, those are very telling, and they scare people a lot. But if a fat mother's telling you these things, there really is, or a parent, a father, or caregiver that you might be working with, this is them really trying to reach out for assistance. And this is the reason why then you will say, you know what, we can call, which I'll talk a little bit later, we could call Access in order for them to send a team to, or maybe you can go to the hospital, somebody to access you, someone to link you. It's not just this emergency, but obviously the ongoing aftercare for your well-being. And obviously, and substance use. A lot of times we think of substance use as just a behavior, but sometimes substance abuse is also a behavior due to some internal mental health issue, or self-medicating, as we hear. So that's also a telling sign. Or somebody who wasn't drinking before and now is starting to drink again, or something. So now I think it's extremely important to differentiate this a little bit, because home visitors work with oftentimes recent moms or new moms, is common symptoms in pregnant or postpartum women. Now, the truth is that this is something that we as a department, but also in general as a society, that we are still trying to really promote more. There's always been this feeling kind of like this is just something that happens when you're pregnant, or you just have a child, and so for a lot of times many moms wouldn't really talk about these feelings. It's almost like, why would you not be happy? You just had a baby. So it's important to know that that's been part of our society in general. So this might definitely affect a mom really being open about their symptoms. But one of the things you can look into is really changes in their mood. How are they reacting from one day to the other, or not changes in your mood? For example, it can be very common for a mom who just gave birth to have what they call baby blues for a few weeks after childbirth. But after some time, it really should start lifting. And so definitely after 3-4 weeks, if this is, or, still going, or 6 weeks, this is still going, this is something we really, you would want to suggest maybe to explore more, or going through to see assistance to explore more. Granted, with that said, if the mood that is being expressed is something to the level of suicidal, homicidal thoughts, that's something you definitely want to address. You don't have to wait 2-3 weeks, but it's more so like you have this a client, a mom, or who just recently gave birth and been feeling kind of sad, hard to wake up, or hard to go take a shower, but now it's been 6 weeks and it's still the same feeling, or even worse. So that's something you want to definitely suggest or explore with them. Bonding attachment difficulties. This is something that many of you, I attend the referral work groups, I've attended different work groups, and I worked with, listened to several of the home visitors talking about this. And this, So this is something, bonding attachment difficulty, attachment is something you look, or many of the people that I've talked to, is something that you guys look for in moms, and it's extremely important, right? It's very telling of something going on in the moms. Again, it might be common for the first 2 to 3 weeks, but after some time, there should be something going on, something different. So it's something to look into. A lot of times now, also intrusive thoughts happen, and this intrusive thoughts, and I'm not calling them psychosis, is sometimes you have postpartum, not just depression, but we also have postpartum OCD, or even postpartum anxiety, and postpartum psychosis. And some of these individuals might never have had these symptoms prior, and this is the first time they're manifesting. So there's this belief that if you had it before, then the only people that had it before would have developed these issues. But research shows that there are individuals who might have never had dealt with depression or anxiety or OCD. So there's more of so it does occur. So be mindful of that. Don't think that just because it didn't happen prior to pregnancy that they should be okay. So with the intrusive thoughts, though, what it is a mom telling you, I think sometimes I feel like I'm better off dead because I don't think I can take care of this child. And it's not necessarily to a level of suicide, but this is something they think about. Or I think of something very bad happening to my child, and not that they want to, and they know it's, I've dealt with moms as I know it's wrong, and I would never do that, but it's sometimes it comes to my thoughts, to my head, and just scares me, and they're them telling you that's important. What, this is, sometimes it does happen to moms, and some moms I feel afraid of, I don't want to talk about this because something could happen to my kid. But the reality is you want to encourage, that's the reason why you want to go get help so nothing does happen. Then feeling that it's a bad mother should not be a mother at all. That's, again, coming with anxiety, or you're feeling depressed, you're not doing well. This one thing I would say, looking at, I know we look at breastfeeding a lot and attachment as well. It's important to talk about how these things might, even though they're great, how they might be providing some anxiety for some moms. For example, a mom that might not be able to latch, or a mom that feels like I'm not able to feed my child very well because your child lost a lot of weight, for example, the first few weeks, can make mom feel bad. So be educating, like it's normal. Some moms do react this way to those situations, but also assessing if these feelings are not getting better. And of course, I think one of the ones that everybody worries about is worries or thoughts about hurting baby. Either they're worried about it, or they're expressing some thoughts of they said some weird things that you think oh, this is not safe. That's something definitely that has occurred, and something you want to consider finding help for that mom. So now you know something of the symptoms. How do we link these individuals to then mental health services? Where will we go? So before then, I will tell you some of what our services provide in general. We provide therapy. Again, all our outpatient agencies, contracted, and even our directly operated, provide psychotropic medication support. So if that's what the mom needs, or parent needs, or caregiver, or the father, that's something that they can get through our clinics. Case manager services, which a lot of times is referrals and linkage, and not just within mental health services. It could be referrals to something else. And support and educational groups. There's a lot of support groups that we provide in our services. And then you would access these services or find a clinic, for example, either by visiting our website, calling the access line, or utilizing our service area H group navigators. So DHMA website. On top, you'll find our LA County website. You can actually just go on Google and put DMH LA County or Department of Mental Health Los Angeles, and you will be directed to our website. And this is, they do change up the front page of what's being talked about, but in general, this is the way it will look. You will have the mission of our director, and this is the icons you will have. In order to find an agency, however, you would then click on the help now that it's right there on the screen. You'll see it here, and you see it here a little bit more focused. You click there, and while you do that, it will take you to this. It will take you either, if you need something right away, here's our access line, contact us phone number, if it's an emergency. If it's more serious, call 911. But then on the right-hand side above our directory, you would say DMH provider directory. And so you will click on that in order for you then to be able to put the zip code, and then it'll populate what's at the bottom, which is a list of agencies that are within maybe 2-mile radius of your zip code that you input. So this is a way of finding a clinic that is nearby, and it's also good for the home visitors especially because many of you are located in certain areas, to maybe start having a list of the agencies that are closer to your area that you work with. Now, Access, this is the Access hotline, and this is the phone number. Now, Access has done many different uses, actually. One of the main things of Access that individuals use is to contact and find out if they have a clinic nearby, or where can they get a referral. But Access is also the phone number we call an emergency. So if you are a home visitor and the caregiver is telling you that they're suicidal or they're wanting to hurt the baby, this is the number you would call. They would then dispatch a team, a psychiatric mobile team, and then they will attend to the house and assess the mom, the parent, the caregiver, whoever it is, to see if they need to be psychiatrically hospitalized, involuntarily hospitalized sometimes. So this is that number that you contact. It's also the phone number that many individuals call at the end of the day, that many people call just to get connection to somebody live, to talk about maybe their feelings. Sometimes they connect them to like the suicide talk or different other hotlines that exist regarding mental health. But another thing that they do in Access also is the fact that if a parent calls or somebody calls, a client calls and potentially says, I would like services and this is what's going on, and they always assess if there's any imminent risk, then they would then, if there isn't, then they are able to potentially, if the person, the caller agrees, they are able to send out a referral through one of our systems that we call SRTS, and they would send a referral to an agency that they talked about, that distance closest, in order for them to contact the client to then actually make an appointment to be seen. Now, they do have about, I think it's 10 business days for them to respond to it. So it's not something that you will be contacted that same day, but you already basically put in some form of referral. So this is another way of doing this. Otherwise, you can just call a clinic that you found here and talk to the intake department and make that appointment. But this is another way as well. Then we have our service area navigators. Navigators can both refer and link, but the role of navigators is that we have about at least three service area age group navigators in each service area, service area 1 through 8. And some of them focus on just child, some do child and Tay, but most service areas have a navigator for child, youth, and Tay. For older adults, we have one person that oversees all service areas. But these individuals know they work out of their service area. They know the service area, so they are mostly involved with many meetings that happen. So they're aware of what's happening in their service area. So they're really good contact. But oftentimes they focus on intensive mental health service referrals. They're the ones who are contacted by the psychiatric hospitals when the clients are being released and they need someone to go, or they need some form like food service partnerships, etc. But they also are contacted by the community, by parents a lot of times, to find out what services, or the adults themselves wanting to find out services for them. So they provide that support as well. But for home visitors, you can use them to refer an intensive service, but you can also use them to consult about a case that you might have and trying to find out, like, I have this client, I don't know what to refer. What do how can you assist me, and so on. So these are the three basically places when it goes, again, our website, Access call center, and our service area navigators, in which you can try to find a resource, a mental health resource for your client. After that, kind of similarly to the service area navigators, but not really a place you would contact for finding referrals necessarily, is the birth to 5 coordinators. These are mental health clinicians. Typically, they are NAPA fellows, so they're infant, family, and early childhood mental health specialists. They do a lot of consultation and program recommendations for children birth to 5, and they also do a lot of coordination of training. DMH hosted a couple of trainings this summer that we invited some of the home visitors, and so we worked a lot with our birth to 5 coordinators on that. Coordinators can provide referrals and can at times link to direct services. Services for children are provided to the family unit, parent, caregiver, and the child. And it's sometimes when you have, I know that we understand that sometimes finding symptoms for 0 to 5 is difficult, but if you have, as a home visitor, if you feel like there's something going on, you can definitely contact the birth to 5 coordinators in your service area to kind of consult with them about what's going on. That information, the list has been sent in the past, so that should be available for you as well. And lastly, really, is understanding that there's a difference between referral versus linkage. Referral for mental health is really like finding an agency, really, like through either our website or Access Center or our Navigators, to find where you can actually go to find out their opening hours, operating hours, the criteria, et cetera, et cetera. And the linkage is really the client being attending and engaged after an assessment and is still going. So sometimes we don't have a lot of power over that. If the family is willing to go, it's going ongoingly. But definitely in the referral, we want to make sure you are aware of where you can, how you can find a service for your client. And again, last thing within this is consultations always available. I see that there is a little typo. This is so this is basically referral and linkage, and this is basically it for today. I know we don't have a lot, an actual audience, so this will be at questions. Some of the questions that have come up in the past is really really the 0 to 5 have come up. How can you articulate that there's a mental health need for our children 0 to 5? So one of the suggestions is to definitely consult for your birth to 5 coordinators, but also to go back to the symptomology that I kind of talked about a little bit on children. You know, looking at their any sleeping habits, and you can talk about those, any changes in sleeping habits or eating habits, or very extreme responses to the environment and general things. So that's usually the question that come up. So that's one thing, but this is my whole presentation today. Hopefully you enjoyed it, and I thank you very much for allowing me this time. Thank you.
Thank you so much, Rebecca, for sharing all this great information with everyone. This webinar will be available on the website, as well as the Navigator document and the service planning area documents for your convenience. Okay, thank you so much again, and I hope you all enjoyed this webinar. Have a wonderful day.
Thank you.